swiftly on now to our next presentation by Dr. Hebah Daradkah. And we're going to be talking to us about minor burn management and burns first aid, and when, what and when to refer, which I think all of us want to have that question answered. So over to you. Thank you ever so much.
Hi, thank you, Sarah, and thank you for the Tissue Viability Society for having me today. So I'm about to speak about something I'm so passionate about. I think Steph invited me to speak about it because she knows how passionate I am about burns. And before moving on to speak about acute burns and management, I want to focus on how to diagnose burns and how to categorize them and classify them clearly, because nurses here are actually the frontliners, or the first people who might see those burns. And if they don't know how to categorize those burns, they won't be able to know how to manage them. And this is why I focus on this during this talk. So basically, just to also give a hint, unfortunately, we have loads of burns. We don't see them on this side of the world, but about 2.5 cases there are per 100,000 people, and they're spread out across 103 countries, where 80% of these burns are which affecting children under the age of 10 years. And unfortunately, they're also clustered in low and middle income countries. The irony is that these people are, they have the heaviest burden of burns, and yet the lowest resources to support them. Why are burns important? Because they have a significant impact on the patient and the families, affecting them either temporarily, permanently disabling them to go on with their life, and sometimes permanently putting loads of economic and physical, psychological hardships on them. Our bodies respond to burns in two different fashions. There's a local response where the body responds to the burn itself, and there is a systemic response where your body just decides to flare up with inflammatory chemicals and decide to put on the emergency mode for the body. And we will discuss that now and to see how we can manage either. This is the Jackson's model. And to understand the local burn effect on the skin, we have to understand this model clearly. Just as an example, and it's a terrible example, but it is the easiest way to get the Jackson's model simplified. If there was a car crash with a bus having, let's say, 100 people in the bus, and those individuals, some of them from the injury, from the crash, died, and some of them were injured and others didn't affect. So we would say this is very similar to the Jackson's model. And when there's a burn to the skin, some of those cells are going to die immediately once the burn is done, which is what we call the area of coagulation. It's the middle part of the burn. The injury cells that are not yet dead, they have not been necrosed, are called the stasis injury. And then the hyperemic injury are the cells that are not burnt, however, they are inflamed. So they are not injured themselves, but they are reacting to the inflammation. So to the burn. And with the correct management of the burn, we either shift the stasis cells from healing, from being alive to dying, or the other way around, being compromised and then saving them. So we either shift them to become part of the necrotic area of coagulation, or we shift them to become part of the hyperemic area, which is the live part. And we see this, and I'm sure whoever dealt with burns have seen that very commonly, where the patient come in with this size of burn, let's say 5 centimeter size, and then in a couple of days you look at the burn and it's grown, as if like it's expanding. Or the other way around is that when you treat it and then it comes in a couple of days and you look like, oh, it's improved, and now it looks like just this part is burnt. So this is the importance of a correct management, whether local or systemic, for the burn. We are looking to aim to save the stasis part. So the coagulative part we can't do anything about. The stasis part is where we want to manage during the first aid, and the hyperemic part is what confuses us with the burn, and we think that is burnt, but it truly isn't. Or sometimes they think that it is infected when in fact it isn't. Of course, types of burns, I'm sure everybody knows: thermal, chemical, electric, and frostbite. I won't go into details, but with their first management, it's variable from one type of burn to another, which we will discuss further on. For the first sight of patients, first things to do is to look at the patient in an ABCD model. I know for patients that are referred by the GP or for clinics, we don't usually see them in an ABCDE model. But if you're dealing with patients in an emergency department, yes, you want to look at, even if the burn is the slightest burn, the smallest burn on their skin, you still want to think of the patient in an ABCD model, because if that burn developed in a closed area where there was loads of smoke, you might miss an airway injury, and that is catastrophic to a patient, and they might not have 1 inch of burnt skin on their body. So as I said, to identify simple burns, the most importantly is to think about these elements: is that there's no airway involvement, the surface area is less than 10% in children or 15% in adults, sparing vital areas such as the face, the palms, genitalia. There are no circumferential burns, which I will show you photos of now. Patients are stable. There are no chemical or electric burns, and simple and superficial dermal burns. These are the elements that we can call that they are simple burns. There is, of course, a referral criteria per country that is variable. I will show you the ones that we have here in the UK, but those are referral criteria to refer the patient from either a primary hospital, secondary or tertiary hospital, referral center, etc. So this is what an burnt airway looks like. The patient will come with a singed facial hair, carbonaceous sputum, slit in the throat, hoarseness in the voice, drooling while spitting, stridor, increased work of breathing, or inability to tolerate secretions. And most importantly, sometimes they won't have any of these signs, and you just have to guess based on the history where they were burnt and how they were burnt. If the patient tells you the fire was in a closed space and I stayed there for a few minutes and there was smoke, I would immediately think of airway injury. It might not show immediately, but it would show within the first 48 hours. When we consider breathing as well, with a burn patient, we want to focus on burns on their chest, which might restrict the movement of the chest when they're breathing. So often this is missed. We look at the burn in the chest as superficial. We're not concerned so much. It is slightly pinkish blisters, but if you look around, you might see that the burn is circumferential and it's affecting their breathing, especially if there's an eschar. When we look at circulation as well, one of the challenges is finding limps to either take blood pressure or blood samples or putting cannula in, and that is where we find the challenge is when we are assessing the limps of the patient who was burned, because they're red, they're burnt, you can't really see or make a comment on them. But we should always focus that if it's burnt on the limb, make sure that it's not a circumferential burn. When it's a circumferential burn, of course, this is a surgical emergency that needs immediate sclerotomy. This is, of course, an indication for referral. So wherever the patient is, it depends on your unit, where you're practicing, it is a indication for referral. I'm not focusing on all of these. What you will see is this, what we call a secondary. So where the patient comes into your clinic, you take history: when were you burnt, how were you burnt, the intensity of the burn, etc. Got allergies, medications that might affect the burn, such as anticoagulants, NSAIDs, anything the patient is on might affect your treatment for the burn. I want you to see this model is how to assess the burn, the local burn assessment. So first, you want to know the degree of the burn or the depth of the burn and the total body surface area of the burn. And based on that, you will decide whether I can manage this burn or I should need, or do I need to refer the burn. And when you need to refer the burn, that doesn't mean you're not managing the burn. You need to cover the burn, start your treatment, be the first line for that patient, and then refer them safely. Otherwise, the burn will get worse until the patient reaches their destined unit. So to assess the total body surface area of the burn, we've got 2 methods or 3 methods, whichever you guys are happy with. The simplest and easiest method is the palm method, which is you measure each palm is a 1%, not your palm, the patient's palm. Because if you have a child who's burned and you assess them with your palm, you might cover the whole body with only 1%. So we look at the patient's palm size and estimate that that is a 1%, and then measure accordingly how many patches there are and add them together. This is a good method for small burns, patchy burns, splish and splash here and there for the patients. The second method is the rule of nines. The body is divided into nine percentages each part of the body. 9% head, palms 9, chest 18, lower limbs 18, and then you go around them. You don't have to memorize these. If you search them on your mobile and just write down rule of nines, you'll see, and you can estimate if the patient's burned, let's say half of his chest, you'll know that that's 9%. And finally, London Bruder's chart. This is a chart where you will see in every burn unit or burn facility. This is the most accurate one, and it divides them very clearly, where you can color where the burns are and then calculate the total body surface area. And the reason I'm focusing on total body surface area is that when I mentioned the local and systemic response for burns, our body responds to burns systemically if the total body surface area that is burned is more than 10% in children and more than 15% in adults. So if I have a burn that is not, there is no airway compromise for me, and I know this patient is burned less than 15% and they're adults, I'm not too concerned with the timing. I've got time to manage the patient. But if the patient is more than 15% adults or 10% in children, that means it's a systemic effect, and this patient is going to get dehydrated from the minute they got injured. And this is where I need to ring the bells and make sure that the patient is properly hydrated, assessed through ABCD manner, and we've covered all the bases for them. The second thing that we need to focus on is the depth of the burn. The deeper the burn, of course, needs more management and might require more interventions based on what the presentations are. So these are the 5 things that you will see in a burn: the color of the skin, whether there are blisters, ruptured, unruptured, large or small, cap refill in the burnt area, suppleness, and the pain in the burnt area. The deeper the burn is, you will see the colors of the skin changing. In superficial burns, they are pink, red. The deeper you go, it'll become pale, and then eventually, if it's a deep full thickness burn, it'll become leathery brown, purple. It depends. Thrombosed vessels, depends on how deep it is. Same with blisters. Superficial burns don't have blisters. Mid-dermal burns will start to show smaller blisters, and then the blisters can grow and grow bigger. They become ruptured on presentation. The more of that, it means the deeper the burn is. And then finally, the third is the cap refill. You will have cap refill that is normal, then it becomes brisk, and then it drops as the deeper the burns are. Same as the suppleness, and the pain will be highest on superficial burns. And as you go deeper, the pain sensation is going to drop. With full thickness, there is no pain because all the nerve endings are burned. So as I mentioned, I want to focus on this, on these burns. The most common thing that I see in dressing clinics or burn clinics is that patients are sent home with no second look. And the second look for any burn, especially mid-dermal burns have to be within 48 hours. The burn, as I said, the area of stasis keeps either burning or improving the first 48 hours. So the burn might present like this, and then after 48 hours, they rupture and become bigger. And what happens is that the other day I saw a patient where she was burned on her groin, and it was a small burn, and whoever saw her didn't bring her back until a week later. And then when we saw her, the burn was significantly bigger, almost double the size. And the mother thinks that the she was improperly managed, when the truth is that no, she was managed. However, they should have been notified that the burn is going to get worse, and we need to see them 48 hours to intervene to make sure that we're making the wound moist and clean for her, to prevent from the area of stasis to jumping into the area of coagulation. So misleading the patient that this is the burn on the first instance is very challenging. And I always tell the burn patient on presentation in ED, I was like, your burn is going to get worse. We are putting everything that we can to prevent it, but it will get worse. Hopefully not too much, but you have to estimate that it will get worse in the first 48 hours. These are the full thickness burns. Hopefully you won't see them. Now let's jump into the part where the nurses get significantly playing in their role, which are the dressings and preventing the infection. So first of all, we need to assess burn, examine the patient, reassess the patient, and then we go into dressing and infection of the burn prevention. First thing to do with any burn, first aid management, is irrigation and cooling off the burn. So if you have a thermal burn, just pop the patient in the shower, and I always recommend 20 to 30 minutes in most of people would take cold water, but I would say just room temperature water or lukewarm water, because you might put the patient at risk of hypothermia, especially if they're kids. So, and also I've seen few people use saline. If you want to run saline for 30 minutes, you need probably 100 liters of saline or even more. So the best way to do it is under running water. If you had a chemical burn that is acidic, you also need at least 30 minutes of running water on it. If it's an alkali kind of burn, you need 2 hours worth of running water. Now, there is an agent called daphlin where it stabilizes the acidic or chemical agent. However, it's not very is not commonly found in all EDs. So your running water is your number one agent if you need anything. After cleaning the burn and making sure that you irrigated and cleaned the burn properly, we make sure now to choose what dressings we are doing. Now think about the dressing as it is. So the skin, role of the skin on our body is to protect the body from losing heat, water, as a barrier from germs and everything getting into our body. So the dressing needs to act the same way. So you need to think of a dressing that is not sticking on the wound, so that when you change the dressing, it's not too painful. The dressing needs to be loose. It's not too tight. It's not too loose enough for the area to swell, because it's the burnt area and it will become swollen due to the inflammation of the area. Do not use agents that obscure the wound if you're referring the patient to be seen by a physician or anyone in a close matter within 2 hours specifically. If the patient needs more than 2 hours to see someone, then you need to put the agent that is more suitable for the patient, and we'll discuss them now, and add silver agents to these burns, especially if they're deep burns, on presentation to prevent the infection from happening. In terms of the role of antibiotics, no. The answer is no. Treatment for burns, antibiotics is no. I've seen loads of patients being given antibiotics on presentation. If the patient does not have acute infection at the moment of presentation, that antibiotic is going to obscure all cultures that we're going to do and will not benefit the patient. So if you irrigate the wound and clear the wound properly and put AG on the wound, will serve the patient significantly more than giving them IV or oral antibiotics. Unless you see infection, you shouldn't give the patient antibiotics. So the first agents that I really like is the silver sulfadiazine, which is the whitish cream that you see. It's very cheap. It's available, readily available everywhere. The only thing that people do not like, some of the burn surgeons don't like it, it obscures the wound. So if they want to assess the wound, they can't do that if you dress them with silver sulfadiazine. So usually I dress the patients in silver sulfadiazine if we're just managing them in our unit. If I'm referring the patient, I would use something else, and I'll show you now. We're using silver sulfadiazine. You can use it abundantly. It can cover large surface areas. Use it in half a centimeter thickness. I'll show you how now in a photo. And just be aware that for patients who have silver allergies or G6PD deficiency, is not compatible. You can't use it with them. It improves the pain, it cools off the wound, and the patients improve significantly. And this is how you apply it: half a centimeter thickness on dry gauze or paraffin gauze, and then dress it. And you have to dress it daily. And you can't use it for longer than 7 days because there's a risk of hyponatremia with it, and it might affect the patient's leukocytes. The other agents that you might use, especially if you're referring the patient from one unit to another on the same day, you can use a silica mesh, a Mepitel, paraffin gauze, paraffin sheet, atropine gelinet, whatever that you have that is transparent. Remember, the rules is that it has to be non-sticking. So you can't put a dry gauze on it. It has to be moist and it has to be loose on the wound. You can use a fusidine acid without steroids. This only used for infected wounds, especially if you've got like a small surface area of wounds where the patient comes in a couple of weeks. And I'm sure you guys have seen this, where patients treat themselves at home for a couple of weeks and then come back with a small patch of wound where it looks mucky, there is foul smell, and it's quite nasty. And however, it doesn't need a debridement or it doesn't need any surgical intervention. You can use antibiotics on them, topical antibiotics. If there is signs of systemic infection, you'll need like cellulitis around them, then you'll need oral antibiotics to be added on them. To dress the patient properly, oftentimes, especially in emergency department, people panic when they see a burn patient, and they undress the patient immediately for dressing. If they don't have the equipment around them, that when they undress them, the patient becomes hypothermic, in pain, screaming and shouting, and it takes you time to load up your trolleys and prepare for the dressing. So I usually say that this is a teamwork, where someone will be running out to get the equipment for the dressing, the other would be undressing the patient, a third would be irrigating the wound, and this way the patient would be managed properly. Don't forget to add adequate pain management. Burns is one of the most painful injuries a human could experience, next to childbirth and renal colics. So these are the most painful things that someone can endure. So burn is one of them. So we usually max out the pain management for those patients. Paracetamol, NSAIDs, opioids, whether oral, IV, depends on the injury and the size of the injury, and the depth of the injury. But if you have like someone who's burned more than 15%, it's all deep burns, full thickness burns. They won't be in so much pain. If it's mid-dermal burns, it's significantly painful, and then you would need to give the morphine or fentanyl, whatever you guys have in your emergency department, with NSAIDs and paracetamol. And don't forget to give them all the ladder of pain management. So prepare your dressing, adequate pain management. You can't be sterile in an emergency department. You can be clean, but you can't be sterile. So don't focus on sterility, focus on having it clean. The only place to have a sterile dressing is in the theatre. Ensure to cover all the edges of the wound, remove any clothes and or jewelry, whatever that you have, without causing any damage to the area. If the dressing is adherent, soak it with saline to kind of remove whatever dressing that they have on, that they brought from home, etc. And then wash it, irrigate it with water. And then finally, when you dress them, your final dressing, make sure that it's not too loose, it's not too tight. And this is a simple image to kind of remind everyone how to remove an old dressing and put a new one, which is remove it, irrigate the wound and clean it. Apply the ointment or cream, whichever that you're using, put a dry gauze or soft bandage, crepe, and then hang or elevate the limb, especially if it was limbs. So someone's going to tell me what if the burn was on the face or on the chest or on the legs. If it's on the face or a chest, the patient should remain in 45 degrees if they can breathe, of course, and everything is insured. If it's on the lower limb, we have to elevate the lower limb. If it's on the hands, I'll show you how you can hang the hands. Elevation of the limbs improves edema significantly. If the edema improves, we save the stasis zone of the burn, so the patients can be so we can save those cells from dying from the edema secondary to the burn. The reason why I put this image always is that we've created a sling out of absolutely nothing. This is a zinc oxide tape that we placed in a very remote area in a part of the world where they didn't have any kind of slings. It's just to show you that elevation is such an important thing. And if we don't elevate the limb, sometimes all of our efforts is gone. And 1 hour of elevation is enough for you to see a significant improvement in the edema of the patient. This is the referral criteria. As I said, there is always a referral criteria to burn symptoms, different from one area of the world to another, different from one country to another. Even in the UK, in the trust, in the NHS, we have different referral criteria. Refer to your referral criteria at the area where they can show you when you refer the patient to either a burn facility or to a burn center. This talk was this is just a summary of a course that I provide for frontline burns on different parts of the world, of how to bridge patients from the site of injury or burn to a burn facility or burn a unit, increasing their chances of saving that injury or that zone. Thank you again, and these are the references. If you guys need to reach out anywhere, please do, and I'm happy to answer any questions.
Thanks, Hebah. That's really brilliant. Lots and lots to take on board there. Really good advice. Yeah, there are some questions. I'm just going to scroll back up. I think what I was interested in particularly is, where you mentioned the second look. And I think when I've looked into sort of burns first aid in terms of an education sort of side of things, a lot of people will pitch up at treatment rooms, practice nurses, minor injury units or whatever. And sometimes maybe it doesn't look that bad. And they think this is, just a superficial, basic burn. I think there's a lot to be done in terms of education of generalist staff, and that second look, coming back, as you say, within 48 hours to see whether, is there an issue, do you think, in terms of general education of our workforce?
So, I've worked here short periods of time, but I can see you. It's hurtful to see. This is a very simple yet a common mistake: is that patients are sent home and nobody sees the injury after 48 hours. Yes, there is definitely a shortage in the education. I think, and the part of it is the turnover. The physician who sees the patient or the nurse who sees the patient is not the same nurse or physician who sees them later on. So they don't really know that, this patient had worsened. If they were consistent with their patients, if that makes sense, they would know with experience that yes, those patients need to be seen within 48 hours. But initially, burn injuries do not stop when the insult happens. They continue within the first 48 hours, especially chemical burns. So it's very, very important to see them. If you're not seeing them yourself, you just send them to a person who would see them, whether they're GP or so. Sometimes patients would not be able to come back to my unit to see them within 48 hours. I take photos of the image, upload them on the file, and then send them back to the GP and ask the GP to make sure that they did not worsen. If they worsen, send them back to me.
I was just going to, sorry for interrupting, but You know, what I think is lacking also across the general public is around the burns first aid in terms of
Mm,
cooling.
mm,
And I know we've had sessions before where they've shown us images of those that were cooled and those that
yeah,
weren't cooled, and
of course.
how that impacts. And you know, to me, it's like a public health thing. It should be on
Yeah,
adverts on the telly because a lot of
yeah.
people aren't aware, even clinicians.
Yeah. So there is we're lucky that we're in a part of the world where the patients read. Oftentimes I have patients who come into me and they're like, oh, we read that we have to cool it for 30 minutes and then cover it with a cling film, and then they come to us. So some of them are lucky. So it is, this piece of information is actually present wherever you look. It's just you need someone to be aware that there is information, first aid information. I always say it's good. I use burn facility, burn clinics or dressings as a point of education for patients. So for simple pamphlets that can be handed out to patients, it remember that if they're burned once, that doesn't mean they won't be burnt again. And sometimes, if not them, one members of the family. So if you hand out these pamphlets or leaflets, they know what to do next. I'm sure that 100% of us attending this course, we all had sustained a burn injury
Yeah.
at some point, getting something out of the oven, etc. So if we knew what to do, it would save us a significant amount of time.
Absolutely. Someone's asked about your measurement, like the palm measurement, and do
Yeah.
you just mean the palm or the palm and the fingers?
No, so it's just the palm of the patient. And I would say palm of the patient because, as I said, we have varied sizes. So I'm petite myself, my hands are small. If I'm measuring a 6 or 7 foot male, my palm is so small. So I would underestimate or overestimate his measurements. So it's important to use the palm of the patient. And remember, the rule of palms is just important for patchy small bands. So usually these bands are less than 5 or 6%. So you're not really concerned with systemic burns. But if you have areas that are more than 10, 15%, you won't be using the rule of palm. You'll be using the rule of nines because you have a whole region that is burnt, half of it or 1/3 of it.
Someone's asking why you'd go for a silver as first sort of line antimicrobial rather than using an alternative such as PHMB, honey, or others. Is it just
Yeah.
because it's your
Ex
specific pathway, or is there evidence that suggests
yeah.
that it's better in burns management?
Right. So as I said, for simple burns, you don't need to use silver. If you're looking at the third or a deep burn that you know that needs debridement, there'd be necrotic tissue there, and you know he needs debridement. This patient, this is where you use that silver, or there is a risk of infection. For example, a diabetic patient that have their burn on their foot. This is where I use the silver. The you can actually use whatever that you want. It does not really significantly impact the burn. If it's going to get infected, it will get infected, whether it's silver or not. The most important thing that prevents the infection is a clean dressing, having it redressed frequently enough to what is needed to be changed, depends on the depth of the burn, and proper irrigation and cleaning, because when you irrigate and clean the wound, you remove all that colonization of bacteria and that debris tissue that will increase the risk of infection. So for burns, to give AG for a burn, I wouldn't put it on a child unless I have a risk of toxic shock syndrome, for example, or I'm looking for an infection in that child, or if it's an elderly diabetic and I know they're slightly neglected and would need time to get to someone else, I would put that AG on as first time dressing.
Brilliant, thank you. Can you just talk to us a bit about blister management? You know, is de-roofing still the
Yes.
preferred management strategy?
So it's a good question. Yes. So debriefing, just remember it's a painful process if you're doing it aggressively. If you're just cutting and releasing the blisters, it won't be too painful. What I do usually is that I debrief them as much as I can, just gently initially when I see the burn. And after 48 hours, it will manifest to show me whether the blisters have grown or decreased. The reason why we are debriefing is to decrease that dead tissue, to decrease the contamination of the burn. So yes, we do it. But remember, if you're de-roofing and you see that there is a deeper burn, you've released a burn from being closed to open. So you remember that you might need to put an AG there to prevent infection because you've converted the wound from a closed wound to an open wound.
Okay, thank you. Someone's asking again about the Flamazine
Yeah,
ointment. Um,
yeah,
and when you redress it, does it get
yeah.
absorbed? Do you have to irrigate and remove any residue before you reapply? Because I'd imagine that'd be
Right.
quite painful.
Yes, exactly. So, with the silver sulfadiazine, it's not an ointment, it's a cream. So it's a water-based cream, which means that most of the body will absorb it, especially if you put it in the right thickness. If you put too much, it might become macerated. It macerates the wound. And if you put too little, it will stick to the wound. And when you remove the gauze, it will take part of the wound with it. So you want to put that 0.5 centimeter thickness because this is the sweet spot where and not to macerate the wound. And remember, with sulfur-sulfidizing, they need dressing daily. You can't leave it for 3 days or 4 days, and sometimes you need to dress it twice daily. So what happens is that you dress the wound, and then when you see them the next day, you remove the dressing. It won't be sticky, and then you will run water on them, making sure you're removing all the debris, whatever that is released from the wound, and then you tap dry and place a second layer of sulfur-sulfidizine.
Brilliant, thank you. Just one final question here. There's a question around friction burns in pediatrics. What would you
Mhm.
recommend?
So friction burns, it's a good question. If it's just the friction burn, surface area is small, you could treat it similar to anything else, sulfur-sulfadiazine. With friction burns, if you look at the burn itself, it's always loaded with bacteria and germs or dirt, because that area where they receive the friction is usually a hard area. So it's like at the floor, carpets, or the tar on the streets. This is how they get it so dirty. The good thing about the silver sulfadiazine is that when you put it and then you put a layer of gauze on top of it, all the water is absorbed by the body and the debris is stuck on the gauze. So when you remove the gauze, all that debris will be on the gauze. So it's a good way to also clean the wound. As I said, dirty wounds need multiple dressings. So if you see a dirty wound, don't put a dressing that will last for 3 days, like AG, and that's it. You need to put a dressing that needs to be changed every day because you need to clean the wound and then you start the healing process.
Really good advice, thank you. And just a reminder, someone's posted in the chat here, very good timing because it is the National Burns Awareness Day on Wednesday, the
Yeah,
15th of October. And
yeah.
a link has gone into the chat as well. And obviously, people would be great if people could get involved. Thank you so much. If I could just ask you
Thank
now
you.
to stop sharing.
All
Brilliant,
right.
brilliant presentation. And thanks for your
Thank you
time
very
again.
much.
Thank you.